We're going to start with the very first presentation, which is Dr. David Katz. He's a medical doctor and preventive medicine specialist in New York. He's with us now on the panel. David caused a storm in the US in late March with an op-ed in the New York Times titled, "Is Our Fight Against the Coronavirus Worse Than the Disease?" It was perhaps the first airing of criticism against lockdown-style public health responses. Despite claims at the time that we didn't know enough about the disease, Katz was subsequently proved right in his suggestion that it was elderly and the infirm who were most at risk. And it was they who needed protection, not the whole of society. David has a YouTube channel called COVID Reality Check, which I recommend you take a look at. And today he's with us and he's going to do a reality check for New Zealand. David, you there?
Mark, thank you. Outstanding introduction, very well framed. It's an honor for me, everybody, to kick this off with a view from altitude. Good morning to friends in New Zealand. It's Sunday evening here in Connecticut. And I am going to provide a view from altitude, and Mark referred to some of the heavy going, and I suspect some of the participants here will take you deep into the weeds of epidemiology and number crunching. I will obviously reference some of the relevant numbers of epidemiology, but I'm going to leave the minutia of R naughts and so forth to my other colleagues, because I really do just want to frame this in terms of perspective. So that's the first critical thing. This is a view from altitude of a perspective that is perhaps being overlooked. Second thing I wanted to say, Mark, is I really have great admiration for Prime Minister Ardern. You know, everybody around the world dealing with this is making difficult decisions in a complex crisis without the best information about all the different options. There's no way to test them. Everything has to be done in real time. And, you know, certainly I am not directing any criticism at decisions that have been made in New Zealand, looking at alternatives. But I think Prime Minister Ardern has demonstrated commitment, effective leadership, passion, compassion. Frankly, I wish we had the same set of attributes on display here in the United States. But let's get to it. In June, when Time magazine wrote about the best global responses to the pandemic, New Zealand had an honorable mention along with Australia. So the winners were Taiwan, Singapore, and Korea at that time. But New Zealand was next on the list because of what Mark just described and what you know so well, essentially a lockdown that prevented any transmission of the virus. And of course, it helps a lot to be in the part of the world that you're in and isolated the way you are, and effectively to be an island nation. But even so, this was obviously policy related. But the trouble with declaring winners and losers during a pandemic is you're doing it in the middle of a complicated race that's really very hard to call. So, you know, who really is winning the battle against this pandemic? And I think there are three ways to look at this. One is that if you have high case counts and high casualties, you're losing. And the United States is in that category. There's no part of the pandemic that we've managed effectively here. So, you know, if you want a place to look to see how not to handle the pandemic, here we are. New Zealand is in this second group, low case counts and low casualties. And that was viewed by Time magazine in June as winning. Maybe some of you view that as winning. I view that as hiding. And I would say there's a third consideration that nobody around the world has really demonstrated, and that would be very high case counts and very low casualties. That would be winning. And let me show you why. One way to think about confronting the pandemic would be a battle. And so you can go out in a battle ill-prepared, you can lose. You can hide away from a battle and it's waiting for you, or you can go out and win it. I don't think it's the best analogy, because the virus is not actively seeking us out. It's just making a living the way its nature requires. So it's really more like a fire than an enemy that's seeking to do harm. It will burn whatever it can burn. It's not thinking. And the other thing is, if you don't go out and confront a fire, it burns anyway. And so what is the pandemic burning down if we don't actively manage it? Well, it's burning through livelihoods. It's burning down jobs. It's burning away people's places of employment that will close down and not open up again. We're very concerned here in the States about the effect it's having on education, socialization, psychological milestones in kids. And of course, it is rampaging through the social determinants of health. While I was waiting to get my cue and start talking here, I was looking at social media feed out of Canada that their opioid and drug use epidemic has surged as a result, byproduct of the COVID pandemic and the mental duress that results from the policies in Canada. So it's a fire. So then let's look again, who's winning? Well, you know, if you go out to fight a huge fire, you're ill prepared, you don't have the right protective equipment, and a lot of people are killed or injured, well, you've lost. That was a really bad response. On the other hand, if you just hide away, you know, in a concrete bunker, you may not be directly affected by the fire, but everything you care about is potentially burning down. And frankly, that's an alternative way of losing. And that's the reason for my involvement here, my concern that I think there's a better way as New Zealand explores what to do in the next phase of all this. So a high case count, low casualty experience for COVID would be the equivalent of you go out, you meet the fire, you're well prepared, you have all the right equipment, and you actively control the fire and put it out. And I think that's what we can and should be doing with regard to SARS-CoV-2. I started opining very early, actually, even before that op-ed in the New York Times, because it seemed to me as data were coming out of Wuhan and South Korea, we were catastrophizing. The media were eating this up. There was a huge opportunity for drama. And so we were getting reports about the toll of COVID in pretty much every news cycle. And overlooked, it seemed to me, in the mix was, you know, here in the United States, for example, we're a big country. 8,000 people die every day without a pandemic, 8,000 people a day. And yet the reporting of the toll of the pandemic would lead one to believe that nobody here dies of anything other than COVID. So we had massive risk distortion that reverberated around the world. I think New Zealand is a victim of that as well. The early data showed very clearly that there was a massive risk differential. This is a really bad disease in the frail elderly. It's a pretty bad disease in the elderly who aren't frail, and it's a pretty bad disease in the frail who aren't elderly. It's a really bad disease in the frail elderly. But in young, healthy people, the risks of this infection are actually considerably lower than many risks we encounter in our daily routines. Certainly with children, for example, the risks of an adverse outcome from COVID tend to be lower than the risks of riding a school bus, for instance. So I was concerned about the catastrophizing. And I wrote this op-ed in the New York Times that ran March 20th, which seems like several lifetimes ago. And the issue I was raising when I asked, is our fight potentially worse than the disease, was, you know, will we maybe harm more people with a society-wide lockdown than are directly harmed by the virus? And what I had in mind was not a trade-off between lives and dollars, but rather the social determinants of health, which are referred to in this Health Affairs article as the social determinants of death. If people are unemployed, if their livelihoods are imperiled, if they are desperate, destitute, food insecure, extremely anxious, a lot of bad things can happen. In the short term, those things include depression, drug use, addiction, domestic violence, child abuse, suicide, and we have seen global surges in all of those. Over time, you worry that the consequences of an unraveling of social determinants can be even greater. And this perspective was shared by three-time Pulitzer Prize winner Tom Friedman, New York Times columnist. So he contacted me after my op-ed ran and channeled my opinions in a column of his own, which he's done a number of times since, ran me up a very high flagpole. So here I am. That's why I've become as visible as I have on this topic. And in Tom's column that followed mine by just a couple of days, we explored the notion of, okay, an initial lockdown, but then a pivot to a risk stratified approach where we recognize that SARS-CoV-2 is not a one-size-fits-all threat. It's a really bad disease in some, it's a really mild disease in others. Can we take several weeks to do a nation-specific data assessment that allows us to know what those risk stratifications are, and then develop more elegant policies, a more surgical strike, if you will, as opposed to open warfare, so that we protect those who need protection, but we don't shut down things that don't need to be shut down. And the other critical consideration is if you have no exposure to the virus, you're obviously propagating no herd immunity. And that means you just remain exactly as vulnerable as you were at the start. But as I explored this issue more thoroughly, I met a number of experts, some of whom are participating in this symposium, one of whom, who is not, to the best of my knowledge, is Nick Bloom, an economist at Stanford. We did a webinar together. Nick cited some of the primary literature that shows the following. For every midlife adult who loses their livelihood for an extended period of time, there is 1 to 1.5 years of life expectancy loss. Well, here in the United States, and obviously the trends are the same in the US and New Zealand in terms of social upheaval, the numbers are very different. Here in the US, 40 million people have lost their jobs as a result of the pandemic. And the estimates are that about half of those job losses are permanent or long-term. So that's 20 million long-term job losses. If you multiply 20 million by, say, let's use the lower number, 1 year, that's 20 million person years of life lost. We've had 160,000 deaths from COVID in this country, and the estimate is that on average, people are losing 10 years to the virus. And I think that's actually high, but even if we accept that number, that's 1.6 million person years. In other words, the life lost from the lockdown is 15 to 20 times greater than the life lost from the virus itself. And that's what I meant at the beginning. There's more than one way for this scenario to hurt people, and our goal should be to minimize the total harms. One other critical consideration, lockdown is in the service essentially of flattening the curve. I met 2 expert mathematical modelers in the early going here, Maria Chikina at the University of Pittsburgh and Wes Pegden at Carnegie Mellon University. They published this article on Medium calling for honesty in pandemic modeling. They actually went into a pandemic model used in the New York Times to argue for flattening the curve. They turned it on and used that very tool. They didn't invent a new tool. They turned on the tool that told us all to flatten the curve and said, if you run it, here's what happens whenever you release the clamps. You've achieved no herd immunity. Your population has had no exposure to the virus. Everybody is completely vulnerable. And if at any point you expose your population to the virus, all of the same horrible things happen on a different day. A just flatten the curve or just lockdown policy doesn't save lives or prevent any of the harms of infection. It just changes the dates. Unless deus ex machina, unless between now and the time you release the clamps, there is a highly effective vaccine mass distributed to your population that works beautifully in everybody, including, by the way, the frail elderly who tend to respond least well to vaccines. But that's what you're counting on. Something you don't have direct control over needs to come in from the outside and save you. Otherwise, if you release the clamps with no exposure, everybody's vulnerable. The bad stuff is just delayed. These were the perspectives that concerned me. I do want to note here, I have not functioned as an armchair epidemiologist opining from the comforts of home. I volunteered. I'm a physician. I did 30 years of patient care. I now have retired from patient care to do other things in public health, but I effectively came out of clinical retirement to volunteer in New York, and I served a number of shifts in an emergency department in the Bronx. I just missed the peak because of the time it took to go through the process of volunteering, but I have seen this up close and personal. So my perspective is informed by actually caring for critically ill patients with COVID. But of note, while I was in the emergency department in the Bronx, ambulance after ambulance arrived with patients from, in particular, nursing homes, frail elderly. And the people who were in the ED who had COVID but were otherwise pretty young and generally healthy, most of them didn't even know they had it. They had no symptoms of it at all. And that bears out the global experience here. I've also argued we don't need to test everybody, not in the US, not in New Zealand, to know what's going on, but we do need a data pyramid. I think the most efficient way to achieve this is representative random sampling, which could be done at intervals, by the way, even with limited test supplies, to know who has this. And of course, in New Zealand, if no one's exposed, you already know the answer, nobody. But if you change your tactics, I think you would want this kind of testing. Who's had it? who has antibodies, and from that group, who developed symptoms, who needed the hospital, who needed the ICU, how many died. Everything you've heard about fatality rates is wrong. Because in order to report any rate, and I say this as someone who's authored multiple editions of a leading epidemiology textbook, you have to know the denominator. Absent reliable denominator data, you can't report a rate. You know the total number of deaths, but you don't know out of how many people who got infected. We have recent data in the United States suggesting that our estimate of 4 to 5 million people infected is wrong by at least an order of magnitude. And so if 40 or 50 million or more have been exposed or infected, obviously the case fatality rates also go down by an order of magnitude. It's nothing remotely like 3%, it's more like 0.3%. And the global data suggests that as well. And that doesn't mean you should haphazardly expose vulnerable people and take even a 0.3% risk, because that risk is concentrated in the vulnerable, so it's higher there. But what it does mean is we have massively distorted the magnitude of the risk for want of a reliable denominator. One of the few places that did a good job getting the denominator early was South Korea. They went out and in Seoul actively tested 200,000 people within days who didn't have symptoms, and they reported some of the lowest rates of severe infection of any country in the world. Most of the rest of us around the world are way behind in denominator testing. So as a result of these considerations, what I have advocated from the start, and I've not seen a reason to change my mind, is total harm minimization. Look at the potential, and the title of this talk, as you saw, was Look Both Ways Before Crossing a Pandemic. You look in one direction, you see the potential harms of infection. We need to minimize those. And the best way, I think, to do that is a risk stratified approach. You look in the other direction, and you see the harms of interdiction done haphazardly. You shut everything down, you cost people their livelihoods, and you do a great deal of damage to health mediated via the social determinants of health. We want to minimize both. And the way to minimize both is a risk stratified approach, which, by the way, can be a beautiful phase too. So New Zealand doesn't have to choose, in my opinion, between staying locked down until there's a highly effective vaccine or opening up and exposing everybody and being at risk. We can control waves of the pandemic by letting them be our waves, not waves of viral exposure, but waves out into the world, the lowest risk group first to see, okay, actually, if the virus circulates but nobody gets severely sick, that's actually a good thing. That's how all pandemics historically have ended. Virtually no pandemics have ended with Deus Ex Machina. No pandemics have ended with a vaccine. Certainly the 1918 flu pandemic did not. It ended because the exposed population bore the brunt of it and got over it, and herd immunity was achieved. We don't want to do that with mass casualties. There's a better way. And so we can learn from the follies of history. We can learn from the global experience. And by the way, I haven't seen any country do this. So I'm obviously leaving these slides behind, and you'll all have access, but I've developed this simple color-coded risk grid. There's age-related risk in tiers, and then there's health-related risk. And I think we could stratify the population and adapt our policies. And for the sake of time, I won't dive into the details of the cells, but one of the critical considerations, I'm a preventive medicine specialist, those white arrows indicate opportunities to go from one risk tier to a lower risk tier by modifying your risk factors. We can't change age. We absolutely can change the health factors that most relate to COVID. And by the way, we can also measure them at the individual level and quantify them. Associates of mine at a company called Everest Health have developed a very elegant personal COVID risk calculator that expresses your risk of hospitalization, ICU, or death if you were to get infected. And it's all based on information about your personal health status as well as your age. You could learn more about this at everesthealth.com, but we're very interested in leveraging the power of that. But before we had a COVID pandemic, we had pandemics of chronic disease, which we were mostly overlooking. In fact, diet alone in the United States kills 500,000 people prematurely every year, and it's contributing to the COVID deaths by compromising cardiometabolic health. So colleagues and I have published a couple papers in the Journal of Emerging Infectious Disease looking at the prevalence in the US around the world of these major risk factors: obesity, diabetes, hypertension, dyslipidemia, coronary disease. In the US, 60% of adults have one or more major risk factors for an adverse COVID outcome. 40% or more have two or more of these risk factors. The epidemiology in New Zealand is not terribly different. I am sorry for not knowing it as well, but the numbers are fairly similar. We crunched the numbers for the US. This has received high-level attention. New York Times did an article on the overlap between chronic diseases and risk factors for chronic diseases and adverse COVID outcomes. And then our latest preprint, colleagues and I published, is on the opportunity to reduce hospitalization rates by a very significant amount. 36% was our estimate, simply by modifying these very modifiable risk factors. So again, there are heart disease, lung diseases, but in particular obesity, diabetes, hypertension, dyslipidemia. And we know the mechanisms by which these contribute to COVID risk. Excess adiposity contributes to insulin resistance, inflammatory responses that are out of balance, increases the likelihood of the famous cytokine storm, and severe obesity is probably the leading risk factor for bad outcomes in younger people. And often, by the way, when we hear about healthy young people succumbing to COVID, what's being overlooked when we say they're healthy is an extreme elevation of their BMI. So they actually have a major modifiable risk factor. We understand the contributions of hypertension. COVID is, to some extent, a vascular disease. It impairs endothelial function, so does hypertension. So the two together are a double whammy, if you will, on the vasculature, impairing oxygen delivery, compromising vital organs. And so major risk factor, very modifiable. Diabetes, interestingly, in addition to being a major risk factor, there's a very strong gradient with glycemic control. These are data out of China, similar data out of New York City. Well-controlled type 2 diabetes reduces the risk of a bad COVID outcome by a factor of 4 relative to poorly controlled type 2 diabetes. And all of this can be achieved with lifestyle intervention, improved diet, physical activity, and much the same with cardiovascular disease. So rather than belabor this just to move along, massively elevated risk with factors we could fix. And I really haven't heard a lot coming out of New Zealand, which I think, again, I applaud the overall enlightenment of Prime Minister Ardern, but there's an opportunity, I think, to say, well, 2 pandemics are better than 1. We have a lot of chronic disease and risk factors. There's an opportunity here actually to improve overall health. I would argue there's never been a better time to focus on getting healthy now. And if there is an alteration of the overall policy approach in New Zealand, this should be configured into it. So, obviously your situation has changed. You were hiding away from the virus. There were no cases. Now you have some cases. You're back in lockdown. The problem with the current approach, which is really all about avoiding exposure to the virus, is you're all vulnerable, and that never stops until something comes in from the outside. And each time you let the population back out, this can happen again. So rather than an either or choice, I'm proposing the middle path, total harm minimization by means of risk stratified return to normalcy. Sweden obviously is the opposite extreme. They let everybody stay exposed all along. I think they suffered casualties they need not have. I think they could have better protected the frail elderly. But at this point, it's unclear who really is the winner, because obviously it appears now that the pandemic is largely behind them. So I don't think we need to pay quite so high a price, but we're in the middle of this, and it's really far too soon to say which is the winning policy. But we should be looking at all the options and trying to use all available information to the best we can. I live in Connecticut. We are fortunately in green because we're in the greater New York City area. And what we can say here is the United States is sort of Sweden by accident. We do not have effective leadership right now. We have bungled our way through the pandemic. But much of the country, which liberated haphazardly, now has high transmission rates. But those parts of the country that experienced the brunt of this early, we now have extremely low and falling transmission rates. And it looks like the pandemic is mostly over here, and the rest of the country is headed in this direction. So I will leave it there. I hope I didn't take more time than was available to me. And Mark or anybody else here, happy to take questions at this point.
David, that's great. Thank you. We do have a lot of questions that come through. I'm going to try to get through as many of them as I can. In some cases, people who are submitting questions, I'll be combining them together. The first one, David, is I just wonder if you could talk a little bit further around the concept of controlling it with the waves concept. You're talking about that we control the waves. With one of our leading people here, David Skiggs, said over the weekend that we really had to do something else besides lockdown. I'm wondering whether you could give us a firm description about what those are. As I understand it, you're saying definitely people improving their health as much as possible. That's going to make it less likely that you catch COVID or that you get badly affected by it. But also, if you could address perhaps things like masks, which are popping up all over the place here now, tracking and tracing, and some of those other ways of perhaps isolating or introducing just the healthy population to the disease.
Absolutely. So first of all, Mark, there's a lot more information than I can provide in the time available here, compiled at truehealthinitiative.org. That's a nonprofit I founded, and we've used that site to organize peer-reviewed articles, essays, risk models, and we detail total harm minimization via so-called vertical interdiction there. It's a challenging question to answer because I don't know any nation that has done all of the necessary work to practice elegant risk stratified interdiction. I think, frankly, it's a 1,200 or 1,500 page policy manual. What I regret is that when countries went into lockdown, New Zealand or any other, there wasn't a statement that we're going to lock this down, but we recognize these massive risk differentials, and we'll be back to you in X amount of time, 2 weeks, 3 weeks, and between now and then we're convening an army to work on Plan B. The very purpose of this symposium: is there an alternative approach that is more effective at minimizing total harm? But when I talk about waves, Mark, what I mean is, again, people under age 50 in good cardiometabolic health have orders of magnitude less risk from this disease than people over 70 in poor cardiometabolic health. The mortality experience is massively concentrated in frail elderly people. And the global risk among people under 30, unless they've had intensive exposures by, for example, doing bronchoscopies in hospitals, or they have some severe health risk, extremely low. And the risk to children, as I said, is globally appears to be less than the risk of riding a school bus. That has been distorted because every adverse outcome, particularly if it's an anomaly, makes global news. And so, if there's a case in a child, if there's a death in somebody under age 30, it's in the news, it's right in front of us. But these are very, very rare events. And the fatality rates by age group, we collated that information at the True Health Initiative site. So the waves that I'm talking about would essentially be: use a color-coded scheme for the population, and say everybody who is in the green cells has no restrictions, return to the world, school, work, essentially you are at liberty to return to life as we knew it before the pandemic, which, in a country like New Zealand, until there's more transmission, may still mean a very low risk of exposure. But in a country like the United States would mean you're very likely to encounter the virus. But actually, it's probably a good thing, because you get it, you get over it, you make antibodies. And again, maybe this pandemic will end with a highly effective vaccine developed faster than one ever has been before. But pandemics historically have ended with herd immunity. And there's a lot of interesting information on the topic of herd immunity, Mark. I think that's also been distorted. We can return to that. But I would, when I talk about waves, I would literally talk about a return to approximations of pre-pandemic normalcy, based on those color-coded risk tiers of the population. So the lowest risk people out first, followed by the next, and essentially a 2-week delay each time to see, is there any bump in hospitalization? Obviously, we ought to do testing, whether it's systematic or representative random sampling, to see what transmission is like. But if I can refer back to the beginning of my slide deck, I think winning this looks like a high case count, but no spike in hospitalization. In other words, people get it and get over it, but it's mild, because people who can safely get through this infection are the ones who are exposed. But we don't get a spike in hospitalization or death because people who can't be exposed don't get exposed. And then if you phase out, 2 weeks, so you basically you have no indications of spikes in hospitalization, then the next wave is out, and then the next wave is out. And we work our way through this. And that gives you time at each step to extend the restrictions on the more vulnerable. The other thing this requires, Mark, and there's no way we can pretend this is not nuanced. And it's one of the problems we have in the world these days. We tend to like yes, no, either or kind of decisions. We're very bad at nuance. But what about, okay, so we're letting lower risk people return to normal activity. What about their interactions with higher risk people? What about multi-generational households? What about, when kids going back to school interact with their grandparents? Well, what we need in place, and this needs to be a combination of what's required by the government and some degree of responsible behavior by individuals. And I think there is a case to strike a balance. I've actually talked about hierarchical responsibility here, where you need government policies, you need organizational responsibility, restaurants and public facilities that determine, okay, we need to comply with government policies, but there are different ways of doing it, and we pick the one that works best for us. And then you need individual responsibility. So, I think masks, social distancing should be imposed anytime someone from a lower risk group is interacting with a higher risk group. And you can start to see why New Zealand and the rest of the world gravitated to what really were very simplistic choices. Lock it all down or liberate it all. They're simple. There's not much nuance there, right? So I think that dichotomy gives us a bad set of choices. I think they're both bad. The only thing bad about total harm minimization is that the how, risk stratification, does require nuance. So, essentially you would need to think, okay, I can behave a certain way. If I'm a kid interacting with other kids, if I'm a young, healthy adult interacting with other young, healthy adults, I don't really need to worry at all about protection. The minute I interact with my parents, I do, right? So there's some subtlety there, but that is the price we would need to pay for a better policy than lock it all down and wait for a vaccine.
Thank you. Hey, you just mentioned recently an article about second waves. Is there such a thing?
Not yet. And so, it's really, just to be clear, I have colleagues, you'll probably hear from some during the symposium, who will sound more confident than I. I'm okay with that. I think we've got to be really humble. And I think anybody who says anything about the pandemic and acts like they've got total certainty is just not paying attention. Pandemics are unpredictable. Any of us could be wrong. So we're talking about doing the best we can with the information we have, being realistic, being dispassionate, looking at the data, interpreting the data, knowing when we do and don't have a denominator. As best I can tell, Mark, there is no second wave anywhere in the world. There is the New Zealand experience, where people have essentially kept people and the virus apart and then let people go back out and get exposed, but the virus never went away. So a second wave of a pandemic, seasonal flu is a good example. So your behavior stays the same, normal behavior. There's a high circulation of flu. The flu circulation and transmission dips to near nothing, but you didn't change a thing. And then the flu comes back because of a seasonal change. That's a second wave. The virus controls those waves. It went away, it came back. SARS-CoV-2 has done nothing of the sort. Every place a population is exposed, the virus continues to circulate, and the only thing that has caused it to stop is the population has developed herd immunity, which Sweden appears to be doing. Frankly, I think we've done it here in Connecticut, or people hide away from it. So there's no evidence anywhere in the world yet of a second wave, and I don't, and I've conferred with experts like Mike Osterholm who are very cautious about this. Maybe there'll be a second wave. Yeah, but in order for a virus to come back in a second wave, it needs to have gone away. And this virus didn't. So, it's your winter. It's our summer. We're in the middle of our summer. And SARS-CoV-2 is circulating quite rampantly throughout the entire country. There's no evidence that this virus is in any way deterred by the heat of summer months. Now, ordinarily with a flu, we would not see high levels of circulation during the summer. The flu, I guess, is a lazy germ. It takes the summer off, but SARS-CoV-2 has just kept working straight through the summer. I don't see any evidence that we are at risk of a second wave. Can't know for sure, but this appears to be, this virus will infect you if it can. It doesn't seem to care at all about seasonality so far. And once we get through it, since the population will have been exposed and the virus will have had its chance to confront everybody, it doesn't seem likely to me that there's a big second wave risk. So I'm hopeful about that.
Thank you. Now, as the real mortality rate is beginning to become evident, and to people like yourself, it was a long time ago, but as it's becoming clear to, I think, the wider public, worriers are beginning to focus on the ideas like COVID-19 causes long-term damage, even though you might not die from it. You're hearing things like scarring of the lungs, myocardial inflammation, long-term problems that people have to live with. What from your perspective and from what you've heard or have seen, what are those effects?
Yeah, so there does appear to be, there are a number of them. Obviously, one of the things that was missed early in the pandemic is that blood clot formation, thrombosis, was a common complication of COVID. And so we were hearing about strokes, and they were being described as if they were long-term, unexpected consequences of the disease. We now know that the pathophysiology of this disease involves the vasculature, increases the risk of thrombosis, and it's now standard care to use antithrombotics when people are being hospitalized for COVID, and that effectively prevents that particular complication. But the other, and the one you're referencing here, Mark, is a fairly significant myocarditis in a subset of patients. And the distortion there is that this is being reported as if it's a very prevalent complication, but most of the data I've seen are in people who've been hospitalized, which are a very small segment of the overall population. Keep in mind, we talk about 4 or 5 million cases in the United States, but we have seroprevalence data from around the country suggesting that we've had 50 million cases and maybe more. Because actually we have other data suggesting that only half of people who get exposed wind up making antibodies. So maybe 100 million people in the United States have been exposed, half made antibodies. So then what is the prevalence of the myocarditis? It's extremely low. It's, again, you need a denominator to know what the threat is. So one of the distortions here is these complications are being seen in patients who have severe infection in the hospital. The other, Mark, and again, this just to go back to a comment I made, and I'm not in any way insensitive to the toll of this pandemic. It's touched me personally, friends, family. So, I feel the human toll of this, I really do. But that doesn't change the fact that we are distorting it massively. So 8,000 people die every day in the United States without a pandemic. That's a big number of miscellaneous causes. We are mortal. We're all going to die. Well, similarly, a lot of systemic diseases cause cardiac inflammation. In fact, there's a cardiomyopathy called Takayasu's cardiomyopathy. Many listening in will have heard of it, which is a common consequence of almost any major organ system disease. You have cardiac dysfunction, a decline in your ejection fraction. It's transient, but it's a consequence of essentially multi-organ system failure during any serious systemic disease. It could be an infection, it could be pancreatitis, it could be any one of a number of things. So this is not in any way unique to COVID. And the reporting we're getting, since it's all COVID all the time, makes it sound like, wait a minute, there are these long-term dire complications of this disease. Well, yeah, I've treated patients over the years with pneumonia, pneumococcal pneumonia, who were still weak and short of breath 6 months later. A year later, they were fully recovered. Well, we haven't had a year for anybody to make a full recovery from COVID, but people who get severely sick and stay in the hospital for a couple of weeks or a month, for any reason, take a long time to get better. We're reporting it as if COVID's the only thing that does that. It's a standard experience after a major systemic disease of any kind.
Right. One last question in the time we've got. Thank you. And it's about New Zealand. So you say we've been hiding. What do you think is the right way of us stopping that? What could we do next? What's our solution, given the what you're explaining about the States, although the effect has been bad, you're implying that at the least you're gaining some sort of extra immunity above it. Which
but don't do it our way, right? So no. You can look to the United States, for how not to handle it. I mean, we are the worst because, again, we're sort of like Sweden, but accidentally. At least Sweden did what they did on purpose. The United States has been ineptly managed through this. So you're better off than we are. You still have the option of controlling your destiny. We basically just let the virus run over us like a bus. No, so what I think you ought to do, so you know, again, you've effectively shielded almost the entire population from the virus and suffered a very low toll of casualties, and I think that's wonderful. But rather than continue with a just flatten the curve, you could do that. But then, you know, essentially every time you let the population back out, there'll be a few cases and you'll lock down again. That's a horrible way to live for an indefinite period of time. And you are waiting for Deus Ex Machina. The only way this ends, if that's the national policy, is relief from the outside, a highly effective vaccine mass distributed. Until that happens, you're stuck. Get unstuck by pivoting to a risk stratified return to normalcy. So again, there's some subtlety required, but maybe the group that's assembled to discuss Plan B is the very group that could help detail the policy responses. How do we manage interactions among risk tiers? But let's risk stratify the population of New Zealand. Let's return to normalcy, and let us not lock down just because there's a rise in cases. We expect a rise in cases. It's a virus. It's going to infect people. But if nobody gets really sick and nobody gets hospitalized and nobody dies, it's okay. We live with infectious disease in the world. Infectious diseases infect people. That's how they propagate themselves and survive. We want to avoid them if there is a high risk of a severely adverse outcome. But you know, just being a case is not a bad thing. I think right now New Zealand is conflating any case with a calamitous case.
Yes.
I say prevent the calamitous cases, allow the cases, because then you have two ways of putting an end to this. One would be that highly effective vaccine we're all hoping comes sooner than it ever has before. Okay, that would be great. But we don't know yet. You know, they're just beginning phase 3 trials. Everything may fall apart. We may be back to the drawing board. The other way to get there is to get through this with herd immunity. And again, I think we're much closer. Many studies suggest there's a much higher seroprevalence than we've been able to document. We may be much closer to herd immunity than we realize. I think essentially New Zealand could achieve the herd immunity of Sweden without the casualties by doing a risk stratified return. That's what I'm proposing. And that means, okay, stay in lockdown for the 2 or 3 weeks or however long it takes to develop that policy manual. Yeah. How do we artfully manage the interaction among our risk groups? But, you know, it's not rocket science. We could put that manual together.
David, thank you very much for your time. Really appreciate it. It's been wonderful. It's a great opportunity to have you come and join us and offer some solutions to New Zealand. Really appreciate your time. Thank you.
Pleasure to be with you, Mark. Thanks for having me.
Right. Thank you.